Hello, a very good morning. I would like to thank the organizer of the third China-ASEAN Health Cooperation Forum for the Critical Care Medicine Forum and the 13th Western Forum of Critical Care Medicine and the Guangxi Society of Critical Care Medicine Congress 2020. I would like to convey my sincere thanks to the organizer who actually giving us an opportunity to share our experience in managing COVID-19 in our local setup. First and foremost, actually, this presentation has been prepared by a team of us from our emergency department, helping out actually in our fight against COVID. The outlines of presentation, actually, we're going to look into the Malaysian perspective, especially with regards to emergency medicine initiative in managing COVID-19. There will be components of preparatory phase where actually we try to get things ready for this particular pandemic. And then we start facing the storm or the collision at the height of the pandemic, where actually we need to make the necessary change, adaptation in ensure that we're able to overcome the challenges. And finally, actually, we are moving towards the new norms in order for us to sustain the fight or the success that we had against COVID-19. The challenge that we face for COVID-19 is very difficult. We know that in an emergency medicine setting is very much battles against the unknown, whereby actually the cases was undifferentiated, very much asymptomatic and atypical presentation. At the earlier phase, actually, we are not sure what is the mode of transmission. And our main concern actually is protecting our staff against this particular infection so that our organization will not crumble due to the COVID-19 issues. And finally, we do not know to what extent that the fatality can cause due to COVID-19. Henceforth, in order to overcome these challenges, the approach that we carry out actually is an end-to-end solution. The most important components actually is the critical governance in order to ensure infection prevention and control, which is the IPC, to detect, isolate, and treat the patient that we suspect to have COVID-19. And secondly, we have to protect our staff, which is the healthcare workers, which has become the main pillars in ensuring the fight against COVID-19 is a success. The third, we have to make use of whatever available resources that we have in our country, in our setup. We have to be innovative, we have to be creative to ensure that the resources that we have able to manage COVID-19 up to the levels that we want. And finally, we determine to ensure that the quality of service that we provide is to the highest with regards to the current updates and findings that we had along the way with regards to management of COVID-19. For emergency medicine and trauma services in Malaysia, I think this is the overall end-to-end solution or the end-to-end framework that we have, where actually patients arrive in our center, either walk in or by the ambulance or referred from the third, what I call facilities, healthcare facilities. The patient will be triaged accordingly and subsequently undergone a diagnostic, therapeutic, and resuscitative effort. And finally, either the patient will be discharged accordingly, which is the large majority of them, and 1/3 of them will finally will end up and be admitted to the hospitals. It's not just that, actually, we have to ensure that the management of patients with regard to COVID-19 do not infect other patients which is not affected. And we have to protect those who high-risk patients that can possibly pose a higher risk in terms of morbidity and mortality. This is our Malaysian timeline. When we heard about the outbreak of COVID-19 in Wuhan back in December 2019, we already start our preparatory phase. And by January, end of January, we start to receive our case, reported our case reported. And then by the end of February, we met the real challenge whereby the largest clusters of local transmission being developed, and it reached the height at the mid-April and mid-March, and subsequently we're able to control the situation till late August. In order to cater for this, actually, emergency medicine fraternity have to develop the emergency preparedness plan. We are lucky because we learned from the previous outbreak with regard to MERS-CoV, SARS in our center. We're able to prepare our emergency department, especially with regard to pre-hospital care preparedness, our decontamination services, our emergency isolation ward, and also stockpiles of the various resources. Though it is very difficult for us to do this necessary preparedness, but we have to make do because surely COVID-19 will arrive to our shore. It's not just that we need to come up with a new solution in order to ensure that we're able to cater for the mass numbers of patients that are going to arrive to our centers. Being a largest hospital in Kuala Lumpur, which is a hybrid hospital for management of COVID, we not just have to cater for COVID patients, but also we have to manage the non-COVID patient as well. So when the storm start to building up towards our shore, we already started our what I call coronavirus mass screening area. We start to operate those areas at the end of January before the largest numbers of patients start to come into our shores. And along the way, there's few adaptation in terms of the management need to be carried out to ensure the sustainability of the services, that it doesn't affect those non-COVID patients, at the same time protect our staff actually from infected by COVID-19. The first thing that we do, we have to do what we call the preparation. When actually Wuhan outbreak made known to us, we need to create a system and pathways in order to capture those patients early, to identify and isolate them early, then to ensure that those that being discharged to the community will not transmit the disease to the others. And we have to also to have some preparation in terms of structures, isolation ward, decontamination services to capture for these particular issues. We have to train our staff in new ways of managing patients, limiting the transmission not just to healthcare workers but also to the other patients. And finally, we have to equip our department with the necessary medical equipment to cater for the disease. So what are the systems that have been developed? We developed a system of screening whereby any patient that come to our emergency department will be triaged accordingly based on the epidemiological link. And for those who are actually stable patients will be directed to a dedicated area for the purpose of screening. And for those unstable patients with a dedicated what we call epidemiological link, those patients will be managed in the decontamination area where resuscitation and stabilization can be carried out. So we are quite lucky because we have a negative pressure decontamination room, which can cater for our unstable person under investigation for COVID-19. However, there is a limitation in terms of the numbers of room available initially in order to carry out resuscitation for the unstable patient. And for those stable patient or walk-in patient, we have to make do a new area to come out just behind our emergency department in order to manage huge numbers of patients that come into our emergency department for the purpose of screening. And these areas that was established in late January 2020, able to cater about 50 patients at any one time. And we're also fortunate that we're able to come out to develop our negative pressure, 12-bedded negative pressure wards, which is the first in our country, in order to cater or to isolate those patients that could have a high risk of infectivity. We developed this initially is not just to manage COVID, but also is in actual fact to manage our PTB patient. But it's the wards has been established or been ready within a time frame that at the same time where COVID arrived to our shores. So it's not just that. Once the structures are ready, we start to carry out a simulation or training process to our staff in order to ensure all the various standard operating procedures or policies being established accordingly. Importantly, hand hygiene and PPE training being conducted regularly to ensure 100% adherence to our staff within a week period, to ensure all categories of doctors or staff that are involved, from the specialists, from the nursing staff and the non-nursing staff, to be in the know of donning and doffing off of the PPEs. We also following handling by the nurses or by our allied support staff in order to make sure that the samples have been taken according to the policy that has been established. So when the first reported case come to our shore, we already in a way developed place. And we have issues of human resource constraint in order for us to govern our clinical services. Then with the good clinical governance from our organization, we're able to pool all the staff from other departments which is not involved directly with the COVID management at the various levels in order for us to work together as a team in managing suspected COVID patients. And education is vital important, especially with regards to donning and doffing of the PPEs that being done regularly to ensure 100% adherence to this particular protocol. And what we noticed actually, when actually the cases starts to rise, that when the government imposed the movement control order in the mid of March, we're able to have an established system within our facility to cater for COVID-19 patients. It's not just that, actually, we also need to change the way that we manage patients in our emergency department. Those patients who have a very high risk for aerosol generating procedures, especially the asthmatics or the COPDs that came in with acute exacerbation, where actually previously we need to nebulize them through the oxygen-driven nebulizer, now is being changed or being converted to using a metered dose inhalers. By doing this, we know that we're able to reduce the possibilities of transmission from the healthcare or from the patient to the healthcare workers or from one patient to the other patient. So these are the adaptations that we need to make. The adaptation in handling aerosol generating procedures, intubation technique with minimal AGP's production, the airway equipment trolley, which provides us also with handheld ultrasound in order for us to manage the intubation processes. We come out with a step-by-step checklist, and we also come up with the educational videos by our medical officers to teach our staff and our healthcare workers to manage AGPs. So these are the examples of intubation checklists that we come out in our organization in order to ensure that the minimal aerosol generating procedures are released to the healthcare workers while doing the particular procedures. So the airway training, we make away using the standardized, what I call the conventional laryngoscope. We move the video-assisted laryngoscope so that we can have a better safe distance between the patients during the process of intubation. We also train our staff using the PRPR, especially in order to minimize the transmission using aerosol. Even though at this time, there's still a controversies about the modes of transmission of COVID-19. We did not advocate using a conventional CPAP for the purpose of non-invasive ventilation. We advocate using the helmet CPAP also on the premise to reduce the aerosols that being generated during this particular intervention. So these are the protocols that we developed for the asthmatic and for our COPD, but because we know from the experience during SARS, by replacing nebulizers with MDI spaces, actually we can reduce the numbers of aerosols being generated, and at the same time it's actually equally effective in in patients with asthma or COPD exacerbation. So we use this particular protocol during this period and it's still ongoing to now. And this is some of the long-lasting changes that we had that we need to carry out to ensure that we release what I call reduced transmission to the healthcare workers and to the other patients. We have to make do with our own spaces because we know at this time it's very expensive for us to buy the spaces. So what do? We modify spaces accordingly based on our local resources to come up with the metered dose inhalers techniques. And these are some of the examples when we audited our patients that using MDI. During the pandemic and pre-COVID-19, we realized that there's no statistical difference in terms of those discharged patients or those patients need to be triaged to other critical zone, where actually we start to introduce MDI spaces, replacing oxygen nebulizers for the mild to moderate acute exacerbation of bronchial asthma. It's not just that. The aerosol generating procedures that are being carried out post-intubation, transfers of the ill patient from one center to the others, using an ISO pods being carried out. This also being done by a trained group of personnel that we develop in our setup to reduce the transmission to the healthcare workers and to the other patients. And thirdly, when we come out actually to ensure that the healthcare workers being protected, because we know using PPE alone is not enough to minimize this transmission. Having a structure alone is not enough for us to reduce the transmission to healthcare workers. What we need, a system in place supported by facilities that are able to separate what I call the dirty and the clean patient right from the beginning. So by doing this, we're able to isolate those potential patients that can transmit COVID to others, healthcare workers. In our setup, we identify early at our primary triage to differentiate with those patients with or without respiratory symptom. Any patient with a respiratory symptom or fever for that matter will be isolated towards what I call a dirty areas or dirty zones. And these are the areas where actually be manned by healthcare workers that adhering to the what we call wearing a full PPEs as if that we are managing a COVID-19 patient. It's not just that. In our resuscitation zone, we develop what I call a clean and a dirty area. There's a very separation between the two in terms of the personnel and structures. These are to prevent the cross-infection in between the patient and between the patient and the healthcare workers. So these are the recommended PPEs that we come up with. It's not just though that is being said in the mid of March, but actually we already come up with these articles of the PPEs usage at the beginning of February. So those healthcare workers is mandated to adhere to these PPEs ethics in order to ensure their safeties and organizational safeties. And any patient that do not have any epidemiological link or do not have a respiratory symptom, these are the patients that will be isolated to a clean zone. And although that this patient is being managed in the clean zone, the healthcare workers that man this area must also adhere to a necessary PPEs guideline that have been developed for them. This is a very important component that we need to establish right from the beginning to ensure the separation of dirty patient or suspected COVID patient from emergency department being carried out and subsequently be managed in the dedicated wards in the hospital setup. We also come out with a local risk certification for SARIS patient because there was an issue either to carry out a PCR testing on this particular patient. So we come up with the consensus with the various departments to risk identify those SARI patients. Even without the swab that we're able to determine the positivities of this patient, those SARIS patients will be isolated right from the beginning. On top of that, another challenge that we have in our country is not just COVID-19. We also have to deal with dengue, which is a local endemic in our country. So these are Dengue's infection is one of the mimickers for COVID-19. So what do? We come up with the posters to differentiate between COVID-19 and dengue, add the triage and also the various clinical features and also point of care testing in order for us to differentiate them accordingly. However, we always have a high risk suspicion of possible COVID-dengue co-infection with dengue if the what I call the clinical features of the full blood count did not fulfill any of those clinical conditions. In order to cater for those management of COVID-19, we realized actually using a conventional chest X-rays is not conducive in our emergency setting because it require what we call additional staff to conduct the examination and also a specialized areas to carry out the examination. So what we do, we invest on using a lung or what I call an portable ultrasound in order for us to screen for those patients who more likely to have a COVID-19 pneumonia. So we use a lung ultrasound during our triaging processes to differentiate between effective and non-effective respiratory symptoms. We use lung ultrasound for screening purposes to differentiate among the COVID-19 pneumonias with the mild symptoms. We also use lung ultrasound as a purpose of diagnosis to increase the sensitivities among person under investigation and SARIs in combination with the history and point of care test. It's not just that, for those patients who have a positive RT-PCR, we use lung ultrasound to quantify the severities of lung involvement that due to COVID-19. By doing that, we're able to facilitate a faster decision-making process, either to admit, discharge, or even to ICU referral. And also we can use lung ultrasound for therapeutic intervention in order to ensure the various areas of the lung being recruited actually when we carry out the ventilation for those COVID patients. So these are some of the lungs ultrasound changes that can be seen based on the severity. But one of the commonest findings that we can observe, especially at the stage 3 pneumonia or stage 3 COVID-19 or pneumonia, COVID-19 pneumonia, there will be involvement of the pleural line. We can see irregular or fragmented pleural line, and subsequently when the severity of the disease become increased, then we can see small areas of what we call skip lesion or subpleural consolidation, and their distribution will be asymmetrical all over the chest wall, and commonly is occur over the posterior and inferior parts of the chest wall. So these images shows an evidence of irregular pleural line, and these are the multiple B line can be seen, and these are the confluence B line can be seen in suspected or COVID patient. By doing this, we're able to stage the COVID-19 patient accordingly based on the severities of in the lung ultrasound. So we came up with our own algorithm. So when we do those patients that person under investigation or SARI patient or patient with influenza-like illness who have abnormal lung ultrasound, we're going to look at the lesion distribution. If there is a distribution in hot zones or posterobasal areas, these are the patients that in stage 3 COVID-19 and is of course going to be admitted to the acute cubicle in our dedicated ward. For those patients who have bilateral multilobar in patchy distribution with no evidence of organ dysfunction by doing a point of care ultrasound and requiring oxygen supplementation to maintain the SpO2 more than 92%, these are the patients that we categorize as stage 4 COVID-19, and these are the patients that are going to refer to our ICU clinic in order for them to be admitted to ICU. And those patients that have a diffuse and generalized findings with evidence of organ dysfunction by the point of care ultrasound, these are the patients that require early intubation inotropic support, and of course admitted to the ICU setup. So all in all, actually what we do, one of the ways that we're managing COVID in our centers, we incorporate lung ultrasound into COVID-19 management in the emergency department in order to cater for what I call various disposition. What about the ICU referral? The ICU referral in our setup, we mainly advocate an early referral to our ICU. Those stage 4 patient COVID-19 pneumonia requiring oxygen supplementation will be referred to ICU. So for example, those patients with acute respiratory distress that require more than 5 liters per minute oxygen to maintain SpO2 more 92%, those patients with hemodynamic instability, those patients with evidence of acidosis, and those patients who actually severe comorbidities or high risk of deterioration. These are the patients that we refer early to ICU setup. In terms of ICU management, I think by then actually it's fairly standard. There's a component of ventilation. We conduct lung protective strategies in selected patients depending on the phenotypes of the COVID-19 pneumonia. So we also advocate prone position for some of the patients. We closely monitored for ventilator desynchrony, especially due to blocked EPT because of the secretion that come out from those patients. And we have to ensure that the patient receive an adequate sedation. We advocate usage of steroids, dexamethasone for stage 3 onwards for those patients with high risk, and of course, patient in stage 4 onwards with or without any other high risk criteria. What about the fluid requirement? So generally, there will be a restrictive fluid strategy. We're aiming for even balance, definitely for strict IO, close renal function monitoring, and of course, the usage of diuretic, very cautious. What about the drugs that we use? We advocate early usage of anticoagulants and some of the antivirals that have been sanctioned to be used for COVID-19 management. So by the end of April, the cases already peaked, and by all these strategies that being what we call implemented in our country, we managed to control the situation, and by the end of May 2020, the cases start to subside. It's unfortunate because currently we are facing the third wave at the beginning of September in part of our states in Malaysia. So by then we already inculcate the new norms that have been developed in the country. This is where we are now. We are still battling with the third wave, which started at the beginning of September 2020. We are still fighting it, but we are lucky because we already have the system in place based on our experience in managing the first and the second waves of COVID-19 in Malaysia. So what has COVID-19 taught us? Preparation is half of the battle. Clinical governance is very crucial. We need to bring everybody in place to make sure there is a collective responsibility in managing COVID-19. We must trust our PPEs because our patients at times do not disclose their epidemiological link. And it's not just trusting our PPEs. We need to make sure there is correct practice of wearing the PPEs. We need to be innovative in a ways that we're managing the patient. We come up with the new techniques of managing ADPs. We come up with the new techniques of managing asthmatics and COPD patients. COVID-19 will be with us forever. What importance? There must be an end-to-end management framework. We have to develop the system that we use now. We have to screen them, detect them, isolate and test, and treat them accordingly. Our triage system in emergency department is already changed. Rather than based on severity alone to categorize the patient, from now then onwards, we use our triage system is going to be based on severity and also the possibility of infectivity. What about our structures? Our structures now have changed. Our emergency department structures now consist of dirty and clean zone, and in order to cater for those patients that have a high risk of infectious disease. And in the way that we're managing patients, rather than using conventional methods, we are using more and more ultrasounds, as our extended tools, and using a focused examination technique to zero in to the various conditions that we have in mind. And finally, usage of PPEs and also using a various medical equipment to maintain a safe distance within our to our patient to ensure the risk of transmission is much lower. So we invest on video-assisted endoscope, we invest on auto-mechanical CPR, closed suction circuit, and R support this transmission. It's actually very challenging to all of us. We are very successful in flattening the curve during the second wave, but to maintain the flat curve is even more challenging. Now, as I speak now, Malaysia is battling our third wave when actually COVID-19 numbers of patients start to increase again. But again, I'm saying we have the experience of managing the second wave, and hopefully by having this experience, we're able to control the third wave in due time. So for all of us, battles against COVID-19, losing is not an option. So we must win this battle. It's not just this battle alone. We must win this war against COVID-19. I think that's all from me. Again, I would like to thank the organizing committee for inviting me to share this valuable experience with our colleagues. And hopefully by sharing with this experience, we can learn from each other in the ways that we can manage COVID that facing this world today. With that, thank you for listening, and all the best.